think I'm going to go eat some chocolate after I finish this video. In fact, I'm just going to say it. I'm going to eat chocolate after this video. It's probably going to be Reese's Peanut Butter Cups. Just letting you know. Okay, so the first thing we're going to talk about are cardioprotective drugs. So while taking chemo, you need to protect your heart because chemo can cause bad things that happen to your heart. So the first drug that we're going to talk about, and I don't know if there's specific categories for these drugs, but these are just the drugs that they listed under cardioprotective. So they, in general, decrease toxicities. Just a fun thing to know. Amifostine. Ethyl. Sounds like ethanol, like ethanol alcohol. Amifostine ethyl. It's available IV, and it's used to reduce renal toxicity when it's associated with cisplatin. So you need to hydrate your patient. So, I mean, it's reducing renal toxicity. So obviously you're trying to protect the kidneys. So you would want to like increase your patient's fluid so that their kidneys can like flush out stuff. I guess that makes sense. Allopurinol, which is Xyloprim, and rasburicase, which is Elitech. So I checked our notes that P is actually not supposed to be there. Our notes had it with a P, and then like on one side it had it with the P, and then on another side it had it without a P. I Googled it. There's not supposed to be a P there. So RASB, rasburicase, whatever. Who cares? You'll remember it. It's available IV or PO, so by mouth or by IV, and it's used to reduce hyperuricemia. These are anti-gout drugs because gout is when you have an increase of uric acid in the body. So allopurinol and rasburicase, anti-gout. It's also a cardioprotective drug, IV or PO. Remember that. Oh, leucovorin. This was the drug that's the rescue drug from methotrexate. You remember that. You should. This is available IV or PO. It is rapidly converted to folic acid in the body, and it protects healthy cells. So remember, methotrexate is like given on Monday. 24 hours later, on Tuesday, the patient comes and gets a shot of leucovorin, or, I mean, since it's also available PO, they could take a pill at home. They take their pill of leucovorin the next day, and this protects the healthy cells in their body from the methotrexate. So dexrazoxane, Zynacard. This is cardioprotective with anthracyclines. I just zoom in on that so you can see that. Dexrazoxane is cardioprotected with anthracyclines. These words are hard, y'all. And then this is the last drug. They actually said in our notes we didn't need to know this, but we're just going to cover it anyway because it's just one drug. Mesna, looks like Mesa. Mesna is Mesnex, and it protects the bladder lining when taking ifosfamide, which is Ifex. So protects your bladder. Chemo side effects. We probably all know somebody that's had cancer. And now that we know what the side effects are and why this is happening, it makes sense. So chemo is attacking attacking cancer cells. But when it doesn't attack cancer cells, it's attacking like the really rapidly reproducing cells in the body. So if you think about what the really rapidly reproducing cells in the body are, like your hair, your skin, your mucous membranes. And then I just have the letter B here. I'll have to go look up what I mean by it. I don't remember what it's supposed to be. But it's, could it be bone marrow? Your blood? I'm going to write blood there. Let me get my marker real quick and write blood in that section. Because I have a feeling it's supposed to be blood. Because your blood is a pretty rapidly reproducing cell. I have added it. It's official. Let me show you the new addition. See, it now says blood. So those cells, like your hair, your skin, your mucous membranes, and your blood, are rapidly reproducing. So since your chemo is attacking, it's trying to attack just the cancer cells, it's also attacking those rapidly reproducing cells. So that's why you're going to see alopecia, which is like hair loss. You're going to see sores in the mouth or sores on the skin, or you're going to see low bone marrow, or anemia, which are things that deal with your blood. Kind of makes sense. So generally, let's just say we have mucous membrane issues, GI tract, alopecia, skin issues, bone marrow suppression, tumor lysis syndrome, and extravasation. Let's start at the beginning. Mucous membranes. They can have stomatitis, which is oral inflammation and ulcers. So you want to provide information for your patients from receiving chemotherapy about mouth care. So you don't want them to eat spicy or acidic foods. You obviously don't want them smoking. You want to have them also avoid alcohol. You want to tell them to use a soft bristle toothbrush so that they don't irritate their mouth any further. They can use special mouthwashes or super mouthwash or saline mouthwash. You want them to stay away from like Listerine or like mouthwashes that have alcohol in them, which would be really, really harsh to the mouth. And you also, if your patient wears dentures, you want them to wear those dentures only while they're eating to decrease the risk of like oral abrasions. You can also have them eat like soft food. One of my EAQ questions was like, tell your patient to avoid eating hard bread, chocolate, and I forgot what the other one was, but it basically is like you don't want roughage in their mouth because roughage in the mouth can cause like little cuts in their mouth, which could mean you don't want them to eat chips and salsa. I couldn't do that. Another area of chemo side effects is the GI tract. So nausea and vomiting, ulcers, poor appetite, diarrhea. So if they have diarrhea, you can give them opioids. I can't say that, whatever, or absorbents to like decrease the diarrhea. For nausea and vomiting, cold food is tolerated much better for patients who have nausea and vomiting, as well as small meals. You want to tell them to avoid fatty or spicy foods, and you want to also avoid a sudden food smell. So if you have like a food tray, you take the food tray lid off before you go into their room so that it's not like a big old whiff of like chicken fried steak right before they eat it, because that can make them like want to puke. There's this thing called complementary and alternative medicine. It's called CAM, C-A-M for short. This can include like peppermint oil, hypnosis, distraction techniques, moderate exercise, music therapy, acupuncture, and biofeedback. These are all things that can help distract patients from nausea and vomiting. So a lot of chemo floors or hospitals that have chemo rooms will have like a peppermint oil diffuser, which is like all the rage now. But that scent can help the patient not focus on being nauseated. Alopecia, hair loss. It can happen as early as 7 to 10 days with chemo or as late as 2 to 3 weeks. The regrowth will happen after chemotherapy has stopped. So 1 to 2 months after. So like if you stop your chemo in January, you could expect hair growth by maybe March or April. It's not going to happen immediately. And that's where they get like that little light peach fuzz. If your patient is going to be undergoing chemotherapy, you want to encourage them, if they do want to receive a wig, to go before they lose their hair so that the wig specialist can most closely match their hair color and hairstyle and before they lose their hair. It's just easier that way. You also, with alopecia, like if their hair starts growing back, you want to tell them to avoid like hair dyes, hair bleach, excessive heat styling tools like a hair dryer or a flat iron or whatever, coloring and excessive brushing, because their hair is going to be very delicate and it could possibly actually change like the texture of their hair when it grows back and possibly the color. Just fun fact for you right there. Who knows? Skin. Patients undergoing chemo can have a risk of palmar plantar dysesthesia, which is essentially like hand, foot, and mouth syndrome, which a mild version of this would be swelling and erythema, so redness of the skin, and a severe version of this would be blisters. The treatment for palmar plantar dysesthesia is just stopping the drug. Bone marrow suppression, this is a big thing, so I'm gonna zoom in on this and let you like pause the video to look at this. For bone marrow suppression, before you do chemotherapy on your patient, you have to check their blood count levels. Now, it depends on what drug they're receiving, whether you're going to be checking the red blood cell count or the white blood cell count or what have you. But you check counts before giving chemo because you do not want to give chemo to a patient who has like no white blood cell count. That's just not a good thing. The chemo is going to deplete their numbers anyway, so you don't want to deplete it anymore. So always check blood counts before giving chemo. Say it again. Always check blood counts before giving chemo. Okay, so here, look at this. Take a screenshot if you need to. Now I'm going to talk about it. Anemia is when you have a decrease in red blood cells. Neutropenia is a decrease in white blood cells. Thrombocytopenia, decrease in platelets. Pancytopenia is all blood components. So like there's some word where it's like pan, or it's like the suffix in Latin is like pan is like over everything. But I mean, you could think of like you're panning over an image, or like span. I don't know. We're going to try to come up with something, but pancytopenia is all blood components. And nadir, whatever you want to call it, NADIR, is the lowest level of blood counts following chemo. So chemo given on a Tuesday, blood counts are taken on Wednesday. You're at the lowest of the low. You at the bottom of the hole. That is NADIR, nadir, however you want to say it. That's your nadir. That sounds like I'm talking like Medea. Hallelujah. That's your lowest level of blood counts. For the blood cell lifespan, neutropenia is going to happen first. Neutropenia is the low white blood cell. That's going to happen 7 to 12 hours because that's like the lifespan of a white blood cell. Platelets is 7 to 8 days. That's how long it'll take for you to see that. And then erythrocytes is 90 to 120 days. So you would see neutropenia before you'd see platelets, which would be thrombocytopenia, and you'd see neutropenia before you'd see erythrocytes, which is anemia, the red blood cells. So again, look at that, screenshot it, remember it. For bone marrow suppression, you want to tell your patients to report any signs or symptoms of a fever or infection to their doctor immediately, because thrombocytopenia or anemia or white or neutropenia or whatever, it can escalate very quickly. So tell them to watch out for fever, watch out for other signs and symptoms of infection. Just watch out for that stuff and report to your doctor if you have a fever. Tumor lysis syndrome is common with hyperuricemia. So you want to prevent it with allopurinol or rasburicase by decreasing uric acid levels. That's what we just talked about. Those are those anti-gout drugs. You can see it with, or you'll see electrolyte abnormalities like hyperphosphatemia, hyperkalemia, which is potassium, sorry, I had to use my brain, and hypocalcemia, which is low calcium. You want to treat with diuretics, calcium supplements, aluminum hydroxide, which you remember is the only antacid that a renal insufficiency patient can take, as well as potassium exchange resin and hemodialysis. Good things to know. We talked about extravasation earlier, but we're going to talk about it again. It damages tissue, and normally the first complaint that the patient's going to share with you is that they have pain or burning at like the site. It's an immediate complication. Other immediate complications can include hypersensitivity reaction, a flare reaction, or anaphylaxis. That's why a lot of chemo is given in the hospital, especially the first time that chemo is given to a patient, so that they can, the hospital can react accordingly. If extravasation is suspected, you stop the infusion. You don't remove the cannula. If possible, you aspirate the remaining drug. You give an antidote if ordered. And you can also, if ordered, sterilely cover the wound, give a hot or a cold compress, and elevate the limb. Of course, all of that depends. The doctor will tell you what to do, like give this antidote, raise the limb, put a hot compress on it, whatever. The doctor will tell you. Just some little things about handling chemo. Chemo can have many negative consequences. So it can cause cancer, which chemo drug causing cancer, wow, that sounds great. So it's carcinogenic. It can cause fetal defects, which is teratogenic. It can cause reproductive toxicity, so it can impair the ability to sustain or create a pregnancy. Organ toxicity, so it can cause hair loss, abdominal pain, or dermatitis. It can also cause genotoxicity, which is chromosomal damage. So it's some pretty serious stuff here. So since it's pretty serious stuff, there are several different precautions that we have when dealing with chemo. You double flush any secretions or anything from a patient because chemo can be excreted the same, like in a very unchanged form. Like remember with the eyes, how we have to give patients eye drops to prevent conjunctivitis. Conjunctivitis. I'm learning these words. You use special disposal containers, you wear the proper PPE, and you have a spill protocol. So remember that video in class, there's a special trash can that the lady's supposed to put the chemo bag in. You don't just like throw a chemo bag around, you put it like in a special place, and you have a special protocol in case it spills, and you make the chemo solution in the laminar flow hood that has like the negative air pressure, whatever, that sucks like all the air up out of it. I don't know. There's special things that you do with chemo. So the next section that we're going to talk about are biologic response modifiers. There's two sections of two classes of biologic response modifiers. We have hematopoietic and immunomodulating. I hope I'm saying these words right. I don't know. Generally, biologic response modifiers alter the body's response to the disease, enhance or restrict the immune system, stimulates blood formation, which is hemopoietic, and it also prevents disease. So we're going to talk about hemopoietic first. This promotes blood component synthesis. So hopefully the patient will have a quicker chemo recovery, and it's just, you need to know that it cannot prevent bone marrow suppression, but it can promote blood component synthesis. So it's not going to stop bone marrow suppression, but it's going to make blood. There's money. Okay, so it's not toxic to cancer cells, and it stimulates the immune system cells. The adverse effect of hemopoietic biologic response modifiers is bone pain. You think about it, since you're making more blood, your bones could possibly hurt. Because like if you use your muscles a lot, your muscle's going to hurt. It's going to be sore. So if you're making more blood, which is made in your bones are going to hurt. There are other adverse effects, but that's the main one that you need to know. Other ones can include edema, nausea and vomiting, diarrhea, rash, cough, dyspnea, I can never say that, sore throat, fever, headache, and blood dyscrasias. So with these drugs, you need to monitor counts, and you need to give them exactly as timed. So monitor counts, it depends on the drug. We're going to talk about them. Epidin alpha, which is Epigen or Procrit. These drugs, you monitor CBC. So you're just monitoring the blood count. It stimulates red blood cell production, and it's used to prevent anemia and ESRD. I don't remember what ESRD is. It's a synthetic of what's already produced in the kidney. It takes about 2 to 6 weeks for the response, and they do have adverse effects of MI, stroke, or death, which I guess could make sense because it's making more red blood cells, and if you have more red blood cells, there's a greater chance that there could be a clot, and those things could happen. Filgrastim is Neupogen. This, you would monitor the white blood cells. It's available SQ or IV. It stimulates the white blood cell production, and it's used to prevent febrile neutropenia in patients receiving myelosuppressive anti-neoplastics. So it's preventing neutropenia in patients receiving bone marrow suppression chemo drugs. Kind of makes sense there. It's a colony stimulating factor. It looks to be the only one that's a colony stimulating factor, so that's probably pretty important. It's given before the injection, given before an infection, but 24 hours after chemo. So chemo on Monday, you get filgrastim on Tuesday before you possibly have an infection. So I guess it's like a prophylaxis drug. I don't know. Prevlekin is Numega. Numega, that's kind of easy to say. It's available SQ. It stimulates platelets, so you monitor platelet counts, and it's used to prevent chemo-induced severe thrombocytopenia. So, I mean, that's kind of simple. Immunomodulating, this alters the body's immune response. So it's for cancer. It's also for autoimmune and anti-inflammatory diseases or infectious disorders. So there is a direct toxic effect on tumor lysis or rupture. So it means that it can carry radioactive things into cells. This drug, or these class of drugs, you tell the patient to report any signs or symptoms of infection, excess fatigue, edema, bleeding, or a loss of appetite. So the doctor needs to know about those things. So there's 3 different types. There's interferons, monoclonal antibodies, and interleukins. These are the only 2 classes where they have a specific drug name mentioned. This one was mentioned just like in words. It didn't have it like bolded like in our notes like as a drug name, but it was like this is a drug. So the first class is interferons. This works identical to the natural cytokines in the body. It's antiviral, anti-tumor, and immunomodulating. It sounds like that could be like on its wait. What's that dating app? Tinder. It sounds like that's like its Tinder bio. I'm antiviral and anti-tumor and immunomodulating. I'm interferon. I'm identical to natural cytokines in the body. I'm losing it, y'all. It's used to restore function and augment its ability to function as the body's defense. So it inhibits the body's immune system. So it's used in autoimmune disorders. Adverse effects are flu-like symptoms and fatigue. That kind of makes sense if you're like inhibiting the immune system. Monoclonal antibodies. We've talked about these things before. They're MABs. They target specific cancer cells and they have minimal effect on healthy cells. There's fewer adverse effects, and you can use them for rheumatoid arthritis, inflammatory disorders, multiple sclerosis, or even organ transplant. It's contraindicated in those who have an active infection or HIV because of immunosuppression. For these drugs, you need to pre-medicate so you can prevent allergic reactions and flu-like symptoms, which would be chills, fever, and dyspnea. So monoclonal antibodies, there's 2 examples. We have adalimumab and infliximab. So adalimumab is Humira and infliximab is Remicade. Adalimumab, it's contraindicated in those who have an active infection. We just talked about that. It's for human tumor necrosis factor. It can be used for Crohn's, ulcerative colitis, plaque psoriasis, arthritis, and rheumatoid arthritis. Infliximab, which is Remicade, is for ankylosing spondylitis, which that is just a lot of letters that someone said we're going to make it a name of something. It can also be used for Crohn's or rheumatoid arthritis. It's contraindicated in those who have severe heart failure. And infliximab has a black box warning where it's fatal for tuberculosis or fungal infections. In my EAQs, it kept on saying that this drug can like reactivate latent tuberculosis in a patient. So you need to know the patient's like TB status when giving this drug. Interleukins is the next category under immunomodulating. The drug is aldeslucan, which is IL-2 or proleukin. Aldeslucan, which that makes sense, leukin. It's a natural part of the immune system. It's for cancer or rheumatoid arthritis. It's contraindicated in those who have an allergy. Obviously, God, it's so stupid when they have to say, don't take this if you have an allergy to the drug or one of its ingredients. Like, no shit, Sherlock. If I'm allergic to peanuts, I'm not going to eat a Reese's peanut butter cup. So stupid. It's contraindicated in an allergy, organ transplant, cardiac, or pulmonary difficulties. The adverse effects of interleukins are capillary leak syndrome. All caps. Pretty sure we're going to need to know that. It can also cause GI upset, hypoalbuminemia, so low albumin levels in the blood, increased liver enzymes, edema, dyspnea, cough, fever, chills, generalized pain, chest pain, infection, and headache. Which that just sounds like it sucks. But capillary leak syndrome sounds pretty crappy too. One of my EAQs did say was talking about why did this person gain so much weight in such a short amount of time? And it had nothing to do with heart failure, but it was because of capillary leak syndrome. So I'm going to see if I can find that on my other notes from this, but whatever. I don't see it. This is stuff I was working on earlier. Don't see it. Okay, the last thing, literally the last thing that we have to talk about are disease-modifying anti-rheumatic arthritis drugs. Disease-modifying anti-rheumatic arthritis drugs, DMARDs. See? Okay. 3 different types. Methotrexate, etanercept. I don't know. And then abatacept. I don't know. Okay. Before we talk about these drugs, we're going to talk about rheumatoid arthritis. This is just some information about it. It's an autoimmune disorder. It causes inflammation and tissue damage, pain, stiffness, and a decreased range of motion. There is no cure. The treatment is usually just to decrease damage and further symptoms in the body. And it's diagnosed by symptomatic and like what your symptoms are, and then a blood test for rheumatoid, the rheumatic factor in your blood. So DMARD drugs prevent the progression of the disease. They slow the onset of action, so it may take 3 to 6 months for you to see like effects of these drugs. It's contraindicated in those who have an active bacterial infection, active herpes zoster, active or latent TB drugs, so we talked about that earlier, and acute or chronic hepatitis B or C. Nursing implications are you need to report to the doctor, or the patient needs to report to the doctor any bleeding, excess fatigue, fever, or any respiratory symptoms. And toxicity may be seen in those who have renal disease or renal insufficiency, liver insufficiency, or respiratory dysfunction. Okay, remember, methotrexate, we talked about this earlier. This is the drug that has the rescue drug of leucovorin with the folic acid stuff. This is commonly used in low doses. It causes bone marrow suppression, and it's given once a week. Etanercept is Enbrel. It inhibits neutrophil, monocyte, and macrophage movement into the inflamed joints. It's also for plaque psoriasis and juvenile rheumatoid arthritis. You must be screened for a latex allergy before having this drug administered to you. The onset of action is about 1 to 2 weeks. It's contraindicated in those who have an active infection, and it can possibly reactivate hepatitis or tuberculosis. And the black box warning is for those with heart failure, lymphoma, or multiple sclerosis. Abatacept is Ornica. There's caution, or you should take caution in those with recurrent infections or who have COPD. And the patient must be up to date with their vaccines because it may increase the risk of infections associated with live vaccines or decrease response to actual vaccines. So those are all of the drugs that we need to know for our test tomorrow. I hope this is going to make it stick in my mind. I hope this sticks in your mind. And I can't believe I just made a whole bunch of YouTube videos of me talking about drugs and completely butchering the name these drugs sound. That's not a word. I'm going to go eat some peanut butter cups and try to figure out why my hair looks like this, because this is a hot mess. At least I don't have alopecia.